Yeah. Hello and welcome, everyone, to the Melanoma Research Foundation's Ask the Expert series. My name is Miriam Kadosh, and I am the Director of Education and Patient Engagement at the Melanoma Research Foundation. We are pleased to have you join us today for this wonderful educational opportunity entitled What's New in Primary Ocular Melanoma Treatment. Today, we will be discussing alternative treatments for primary uveal melanoma to avoid radiation retinopathy. You will also have the opportunity to ask questions during our Q&A portion at the end. Before we get started, I just want to share a little bit about the MRF and our CureOM initiative. The Melanoma Research Foundation is the largest independent organization devoted to melanoma. Our mission is to eradicate melanoma by accelerating medical research while educating and advocating for the melanoma community. The MRF is committed to the support of medical research to develop effective treatments and eventually a cure for melanoma. CureOM is the MRF's initiative to increase awareness, education, and research funding for ocular melanoma, while improving the lives of people affected by this disease. Founded in 2011, the CureOM initiative excels because of the hard work and dedication of its patients and scientific steering committees and the generosity of our community. We know that education is critical for patients to make informed decisions about their care. We have many educational programs and offerings, and they are not only directed at patients, but we create educational materials and events for caregivers, family members, and providers, including educational literature, webinars, animated patient videos, patient and caregiver symposia, and information on rare melanoma subtypes. Here are just a few of our education literature that you can order or download for free on our website. You can order them for health fairs, schools, conferences, doctors' offices, etc. We'll send these to you for free. Here are some of our ocular melanoma education materials that you can also download, and they are on our website. We have 6 animated patient videos and 2 more currently in production. These videos are all less than 10 minutes long and pack in a lot of information with great visual images. If you have family or friends who want to learn more about melanoma, these are great educational options to send to them. I'm very excited to share that the CureOM initiative will be hosting our 14th annual Eyes on a Cure Ocular Melanoma Patient and Caregiver Symposium, taking place April 25th through 27th in Cleveland, Ohio, in partnership with the Cleveland Clinic Cole Eye Institute. You will be hearing a little bit more about this later today. To register, please go to melanoma.org and click on events. We hope to see you there. It's going to be a great event. CureOM also hosts its own vision platform, which is a patient-powered registry focused on finding a cure for ocular melanoma. If you have not already checked it out or have not inputted your information yet, please go ahead by using the QR code that's on this screen. You could also find it on our website, melanoma.org. This is our way of pushing research forward to finding a cure to OM with your help. We also host 2 monthly virtual ocular melanoma support groups for both primary and metastatic patients. One happens on the first Wednesday of the month, and the next happens on the 4th Thursday of the month. So please reach out via email, and I'll put my email in the chat if you'd like to join us for one of the support groups. You can sign up to receive our quarterly newsletter. It's called Eye on OM. This newsletter highlights community events, community members, upcoming support groups, and new research treatments and our advocacy efforts as well. So please do join us. We have a variety of patient and caregiver support services, such as our Patient and Community Forum, Treatment Center Finder, financial assistance and resources, and our Ask a Nurse hotline. So please do utilize these resources that are there for you. There are many opportunities to support the work of the MRF and CureOM through a variety of programs, events, and research funding. We host events such as patient symposia and Miles for Melanoma 5Ks in cities all across the country. So we hope that you will be able to join us at one of these amazing events. If you're interested in finding out more, please reach out at education@melanoma.org to learn more about ways you can engage in the melanoma community while investing in our shared mission. Lastly, the best way to learn more about the MRF and CureOM, including information about our education, advocacy, and research programs, awareness campaigns, and upcoming events, is to follow us on social media. Here are our social media handles on all of the different platforms. Now I'd like to introduce our speaker and do a little bit of housekeeping. We encourage you to use the Q&A box throughout the session to ask questions. The information presented during today's session is for educational purposes only, and any individual treatment questions should be directed to your personal healthcare provider. We encourage everyone to visit melanoma.org to learn more about resources. And at the end of today's session, a survey is going to pop up when you close the Zoom. Please do fill out that survey. It helps inform the programs that we put on in the future. So now I will introduce our presenter for the evening. Thank you, Dr. Arun Singh, for joining us. Dr. Arun Singh is the director of the Department of Ophthalmic Oncology, Cole Eye Institute, Cleveland Clinic. He has published more than 500 scientific articles and has edited several textbooks. He is the editor of the Journal for Ocular Oncology and Pathology and president of the International Society of Ocular Oncology. We are excited to be joined by him this evening and excited to be in person at the Cleveland Clinic Cole Eye Institute in April. Dr. Singh, I'm going to turn it over to you.
Well, thank you so much for the privilege and the generous introduction. I would like to start with the current limitations of management of uveal melanoma. We say we're basically using, at least in the US, mostly radiation and enucleation as the primary treatments. Radiation for small or medium-sized tumors. When the patient is diagnosed with this kind of tumor, we tell them, oh, you get to keep the eye. There's a good aspect of it, but you're going to lose some vision, and patient feels very happy because he's going to keep the eye and accepts the vision loss that comes with it. And if the tumor happens to be large, and we tell them, oh, this eye is too big for radiation, but never mind, when you put the artificial eye, it's going to look good. So again, you're finding something good and something bad that's happening here, but none of that is very satisfactory, obviously. And then talking about the metastasis, we say, well, we have these new tests available, and we can predict the chances of what's going to happen, and we keep looking for it, but we don't have any good treatments yet, at least to prevent it. We might have some treatments to treat it when it happens, but not proven yet to do anything to prevent it. And we'll come back to the trials as we go. And that's the reason we say it's very exciting. This in ocular oncology now we have trials addressing all these aspects of management of uveal melanoma. So we'll talk about 4 trials, and we'll go slow, and we'll have plenty of time to discussion. So we'll talk about radiation damage to the eye and how to prevent it. So the first trial, the DRCL protocol AL, is a trial to prevent radiation loss. So we know radiation is an effective therapy, and the problem is vision loss. Is there a way to minimize it? Is there a way to avoid it? That's DRCL protocol AL. The second trial we'll talk about is a COMPASS trial from Aura, which is to totally avoid radiation and use something else. a laser-based viral vector kind of treatment where you are saying, I'll treat this melanoma and we don't have to use radiation anymore. Just want to emphasize or just mention that the radiation for melanoma of the eye has been there for 100 years. And the reason we continue to use it because it's highly effective in providing local control, anywhere from 95 to 99%. It's hard to get rid of treatment that's so highly effective. And that's the reason we all cling on to it. And of course, accepting all the complications that come with it. And the third trial we're going to talk about is the IDEA trial. IDEA is the name of the company. They're sponsoring these trials or conducting these trials. And this is to say, is there a way we can reduce the tumor in the eye, and that will help reduce the vision loss? Or is there a way we can reduce the tumor so that we don't have to remove these eyes? The large tumor becomes medium size, and medium becomes small size, and maybe we don't have to remove such eyes anymore. And a component of it also tags on to this, the risk of metastasis, to say, can we prevent metastasis? And the last one is the atomic trial, which is designed specifically for it, is to prevent metastasis. And I know most of us are lay people and we don't understand the technical jargon here, but it's good to know that uveal melanoma cells are already circulating in the body by the time patient comes to the ophthalmologist. So everybody has micrometastasis. Micro means microscopic. Everybody has these cells. In some percentage of patients with certain kind of cells, these cells will grow, say in the liver, for example, and become big tumors. The idea is to stop or destroy these cells that have already left the eye. That's the adjuvant therapy, and that's IDEA trial, a little bit of it, and the atomic trial that's focused on it. So we're going to cover all aspects that I think everybody wants to hear about. So let's talk about radiation retinopathy. So we knew a few things about radiation retinopathy. We know it happens a few years after radiation. It's a frequent complication. About half the patients will lose significant central vision from radiation. We know it's due to a leakage in the retina, some inflammation in the retina, maybe lack of circulation in the retina, and to some extent it resembles what happens in patients who are diabetic. Not fully, but to some extent. And also, the risk of vision loss or the chances of radiation damage is dose dependent. More the radiation given to the eye, more the chances of vision loss. That's how you're trying to reduce the tumor size, so reduce the dose to the certain structures, and therefore reduce the chance of vision loss. And we know that certain drugs that are used for diabetes, diabetic retinopathy, like anti-VEGF agents and steroids, can treat to some extent radiation retinopathy. They are already being tried in different centers. And there are other variables that come into play that affect vision, the tumor location. For example, if the tumor is right where the vision is, then no matter what you do, the vision will never be better. And of course, there is a possibility of radiation loss to the optic nerve, which also is in the eye and next to the retina, and the tumor could be right next to it. So there are many things that play into it. This we all understand. But we also don't know many things. We say, well, what happens if somebody gets radiation damage and we do nothing, just sit on it? And we don't know which patients to treat because not everyone will respond to the treatment. And we also don't know when to start the treatment. Should we start the treatment even before the damage actually happens, or wait till the damage happens? We don't know that. We don't know. These are all valid questions, and we have no clear evidence to answer these. And we say, okay, well, let's settle on some injection. Well, how often to inject? We don't have anything to guide that. We also don't know which injection to give. There are many options, so which one to use first. And more importantly, if one is not working, shall we switch or shall we just give up? And mostly, we don't know when to stop. So you can get on with these treatments and you can keep having them for years and years, and we don't know when to stop. For many reasons, the treatment may be continued beyond the need for it. So that tells us we don't know any of these questions. There's no evidence. We can all have opinions, but we don't have evidence. And that's where this trial comes in, Protocol AL. It's a long trial name, but that's what it is. It's faricimab. which is an anti-VEGF agent like Avastin, but with extra properties, and a long-acting steroid, which is fluocinolone acetonide. And the idea here is to prevent vision loss. Because we already know if somebody has vision loss from radiation and then you try to treat it, you don't get very good outcomes. So the idea here is to prevent it. If you can prevent it, perhaps the outcome will be better. And that's the idea, that's the objective. So we have basically 3 groups of patients. It's a randomized trial. And in one group of patients, they will not get anything. They will just be observed till they get radiation, because that will help us understand the natural history, what happens to these patients without treatment. And nowadays, we have new ways of imaging the retina, and we'll use all those techniques to see the onset and progression of radiation damage. Yeah, there are 3 groups: faricimab group, Illuvian group, and observation. It's a large study, 600 patients all across the US. We're aiming for 25 centers. The study's already started. 50 patients or so already enrolled, more than 10 from my own institute. So it's ongoing, and other centers are coming along. There's a lot of, as you can imagine, a lot of regulatory aspects to it, and it takes time to get it all right. So it's a 3-year study and looking at the vision outcomes. So we'll be able to compare different groups, do statistical kind of calculations, and come up with the evidence so we can tell which patients could benefit with the radiation treatment and at the same time not lose any vision. This is the idea of this trial. Leave that aside. Coming back to more important aspects, and of course, the survival. Uveal melanoma is a malignant tumor and has a tendency to metastasize. And if you go back and look at the survival of patients with uveal melanoma across many decades in the US, has not improved. It's kind of remained the same. We have an updated paper that says the same thing. So last 40 years, somebody got melanoma in 1973 versus somebody gets melanoma in 2023. The outlook or the risk of metastasis is kind of the same. I say, why is that? Why are we not making any difference? Hey, you have all this, MRF and QROM and everything, and everybody's trying. Why are we not able to make a dent? Because the metastasis is early. When the tumor is small, that's when the cells leak out of the choroid or the uvea. Just so that you know, uvea is the most vascular tissue of the body. There's nothing in the body that gets more blood flow than the uvea. Uvea is nothing but capillaries. So if you have a tumor in this capillary system, it's going to enter the blood. And that's how by blood it reaches liver. So these cells are sitting there. And in some percentage of cases, these cells in the liver will grow. So it's an early metastasis. That means if you really want to change this paradigm here, you need to do early intervention. That makes sense. So that's also an opportunity to say you must intervene early. Well, intervene early for what? Well, intervene early for a small tumor in the eye. You say, well, I want to treat every melanoma that's small, because smaller it is, better the control rates, better the survival. And of course, and the other part, let me see, is shows up here somewhere. Okay, yeah, let me go. I'm not able to see that part of the skin, but also I'm looking for adjuvant therapy. So you can intervene early in the eye or intervene early before the metastasis shows up, because everybody has micrometastasis. So those are the concepts, and the trials are based on these concepts. So let's say here, let's come to the AURA trial. Now this is to avoid radiation treatment whatsoever. So the first one is to prevent vision loss after the radiation has been given. Here is a novel treatment trying to come up with the outcomes that provides very high local control, at the same time not using radiation at all. I have to say, this would be one of the novel therapies for uveal melanoma. We haven't had anything new for a long, long, long time. We're still using radiation. I have 4 patients tomorrow after 100 years, and in 30 years of my practice, I'm so excited to have these trials come through, because we're looking for new things. This is a trial. Again, you give an injection within the suprachoroidal injection and shine laser to treat the tumor. And through the laser, the tumor cells are killed. And also, it's supposed to generate some immune system activate the immune system, and that can also destroy the melanoma cells in the eye. So it has two mechanisms. This is a phase 3 trial, just it's going across all over the world. They have early results from prior studies. You can see the tumor shrinking here after 12 months. And more importantly, it will stop the growth of the tumor. So all the tumors in this trial would be the ones that have already shown growth, so that after treatment, you can show that they're not growing anymore. This is the way they are going to show the efficacy of this trial. So they're looking for about 100 patients, and they're going all over the world to get very specifically defined tumors that are small and documented to be growing at a certain rate so that they can show that treatment is working. And that's the AURA trial. Leave that aside. Coming back to this graph, which I like, this goes back to our initial publication in 2004 to show nothing really is getting better in melanoma, and it's been so for many, many decades. Coming to the systemic intervention, so-called adjuvant therapy. Well, adjuvant therapy is therapy that's done in addition to the primary treatment. Primary treatment is where the tumor started in the eye, and then what else? Because they are getting metastasis. And for that, we have, let me look at this, go back here. Yeah, so we have this called the IDEA trial or DARVO trial. So darvovasertib is a drug that targets a certain mutations in uveal melanoma and stops the tumor from growing, in fact, which causes tumor shrinkage. So here's a PET CT of a patient that has a melanoma in the eye and that also had metastasis. And this is a patient from Australia. And they gave this medicine for the liver metastasis as an experimental drug. And they also found the tumor to shrink in the eye. And here's a photograph of that. You can see the tumor here, brownish tumor with some bleeding. And after a month of treatment, the tumor is smaller. I would say that so far, we never had any drugs. This is a pill, any drugs that can reduce the primary tumor to such a level. This is almost half the size in roughly 3 to 6 months of oral treatment. There's a pill, and the tumor will shrink. You continue to use it as long as you're seeing a response. And all this is well defined in the criteria. And they're very encouraging initial results in the trials. And you can see one photograph given by the IDEA company. And the idea is to use it before the eye is removed, in case the tumor becomes so small that you don't have to remove the eye anymore. You can switch to radiation. And the eyes that are getting radiation, the tumor will also shrink. And then you may have to give less radiation to the rest of the structures. And then you continue with this pill even after the eye is removed or radiation treatment, because it may have some benefit in preventing the metastasis. But when you say, sorry, preventing the metastasis, it's not really prevention of metastasis, but to stop the metastasis at the microscopic level. That's the more technical or better way of understanding. So this is also happening. And this is the DARVO trial or the IDEA trial. I'll leave that aside. And we know in recent years, is the first time FDA has approved one drug for liver metastasis. We haven't really had any good treatments for patients who have actually had metastasis. And Kimmtrak, Tebi, is the first drug to be approved by the FDA because it's like an immune magnet. It goes to the liver and brings in all the immune cells where the tumor is, and those immune cells will kill the cancer cells in the liver. This is a simple way of understanding without getting into too much of it. But it gives you certain survival advantage. Not a lot, but still, we say, what, 6 months or so. The first proven, scientifically proven effective drug that improves the survival. And there are other ways of treating too. So now they're using the same drug, not to treat the metastasis, but to prevent it from converting from microscopic to bigger tumor. This is called atomic trial. Adjuvant Tebi for ocular melanoma. So as you may or may not know, Tebi is a company based out, this is made by a company based out of England in Oxford. And so this is a European trial that's coming to the US. In 11 countries, you can imagine, they're looking for almost 290 patients. And so one group of patients will receive this drug. It's an infusion every week. And the other patient will get nothing. Because that's the standard. To do nothing is the standard. And then over time, we'll to find out, did this drug or this infusion help to reduce the risk of metastasis? So that's your atomic trial. So that answers a very critical question. I think in all of it, this is the crux of our problem, is this metastasis. So IDEA trial, atomic trial, or other drugs, perhaps in this landscape or in this sphere, are the ones to be, I think, are going to bring the bigger change in the way we manage melanoma patients and the outcome of patients. So, and there are the new drugs that have been approved by FDA for liver metastasis management, and we don't get into too much of those details, but just to say that there are new drugs coming, even or methods of treatment, even for patients who have liver metastasis. So coming just to summarize it here, we say these are the problems we have. We have vision loss from radiation, and we say we're going to avoid the radiation altogether. That's AURA trial. And we say, no, I need the radiation, but can I prevent the vision loss? We say, yes, we have this trial coming from DRCR protocol. And you say, oh, I need to lose my eye. So maybe not. Maybe we can reduce the tumor and we can use darvovasertib for it. Or maybe we can prevent the metastasis with combination of darvo and tebi, 2 different trials. And if it happens to be the patient does get metastasis, unfortunately, then there are newer drugs available. So I think we're not there yet, but we're reaching the stage of nirvana. I would like to say that. This is coming. 30 years in making, but it's coming. So I think the next 5 years, and everything takes time. And so, sometimes we are too late to get new things. And of that, I understand the frustrations there, but it's coming. And it's very, very exciting times in our field. Thank you so much for the opportunity to share my thoughts. Thank you.
Thank you so much, Dr. Singh. I learned a lot from today's session already, and I know that we did get some questions ahead of time. So I am going to ask you that now in our question and answer portion, but to the audience, if you have questions, please do put them in the Q&A and I will ask them aloud. Thank you. We're going to start with our first question. Is there anything that can be done to reverse radiation retinopathy?
So radiation retinopathy is a very broad term, and there are many kinds of it. So we just to talk about it, one say if there's a leakage from the radiation retinopathy, well, that can be reversed. If there is hemorrhage from radiation retinopathy, well, that can be managed. But if there's loss of cells in the retina becomes atrophic, then that cannot be reversed. So there are different kinds of it, and with careful assessment, it can be determined as to what kind of radiation retinopathy the patient has. But in general, even with the leakage part of it, for example, the response is temporary. You say, okay, you get better, and after 4 or 6 weeks, you need another shot in the eye, so it's ongoing. And after some time, after some months of it, maybe a year or 2 even, the benefit gets less and less over time because the atrophic component catches up. So initially you may get good response, and over time the benefit gets lesser. So I would say long-term outcomes not very good, but there could be benefit for say some years. But that's meaningful. You say, I'm 60, say for example, somebody's 63 years old and say, I'm still working. If I can manage my vision for next 2 years and then I lose it, it's still worth something. There's some value to it. So it's not to be minimized. The intervention is not to be minimized, but the benefit is not as much as you would like, for example.
Great. Thank you. Can you share a little bit more about and clarify the criteria for disease-free progression?
Okay. This is for uveal melanoma. Okay. Well, that's a very important question, very relevant. And we tried to answer that mathematically some years ago in a very complex mathematical paper. It's published in JAMA Ophthalmology. It's called Cured Fractions in Uveal Melanoma. Okay. So it's to say that what happens to the patients over long term that you're treated, how many do we actually get this cure from it? So disease-free progression, you can express different outcomes in different ways. But in the end, I've been in the clinic and patients ask me, 20 years I've been around, say, oh, am I cured yet from this melanoma? In a very simple way, that's kind of the question is. And the answer is yes, there are some percentage of patients that will get cured. Yeah, we say that number is actually 60%. Okay. This number is true. There are calculations behind it. 60% of patients will get cured. When we say get cured, they will survive the melanoma. They have melanoma, they get the treatment, and they will not die from melanoma. So they survive this melanoma, and that's 60% of it. But this you find out only about 25 years later, because the risk of metastasis persists for many years. So statistically, we say after 25 years, it's exceptionally uncommon to get metastasis. So 25 years is the cure point. Time to cure is 25. But that's too long. I'm 40 years old, and you're going to tell me that you'll tell me 65 before you tell me that I'm cured from it. It's too long. You want something now. I don't want 25 years. So there are calculations one can do based on certain other kind of statistics, and we say if you survived 15 years, then you're statistically cured from it. We can't get shorter than that. But then the other way to think about this, I have time to explain. Maybe I should continue.
Yeah, no, I'm interested how you jumped from 25 now down to 15. So
15,
keep
yeah.
going.
I'm coming to time zero. I'm going to time zero. So I have to shrink this interval. It's all mathematical gymnastics. So you say 15. So then you go back and look at patients who actually got cured from it. So you have 1,000 patients. We have all the data. We say, okay, 60% survived. Let's say 600 survived. Like, who were those? What kind of tumors did they have? And we say almost all of them have small tumors. And almost all of them have those tumors that have a very good, called a favorable prognostic profile, either DNA-based test or RNA-based test. The genetics in the tumor are favorable. So if you have a small tumor, small melanoma, choroidal melanoma, and the genetic profile is favorable, no matter which test you do, then you have a high chance of cure.
Mm.
So there is a component of, so that's why we say, I want to treat melanoma that's small.
Right.
Because that's one way to eradicate or reduce the risk of metastasis. But that's hard to diagnose small melanomas, and it has own problems, but they leave that aside for the moment. But that's how it is. So we know backwards which one get cured, but going forward, we still don't have that clarity.
Are there any trials or anything in the works for trying to diagnose smaller tumors?
Yes, there is, and there are. And that's a little bit controversial, but I'm going to state it nevertheless. So there are kind of prediction models. You say, okay, well, this patient has this tumor, it has this size, it has this thickness, this much of leakage, this much of fluid, this much of vision, this kind of ultrasound. And based on some mathematics, you say, oh, your risk of this tumor growing, or being melanoma, let's say, equivalent is 50%. But the 50% is really no prediction. It's like me saying it may rain tomorrow 50%. It may not rain tomorrow 50%. Anybody can say that prediction. I don't have to be an expert. I can say, yeah, you could be living on that tomorrow, 50-50. So when it comes down to 50% prediction risk, is actually, in terms of prediction, it's actually meaningless. You really have to be close to 85, 90 to have any meaningful predictions. So our present methods, the way we are doing it, is therefore they're inherently limited.
Mm-hmm.
And if you say, oh, this tumor looks like this, and therefore is 50% that it could be melanoma, and therefore I want to treat it, and that's okay. But also keep in mind that 50% is not melanoma, and therefore you are over-treating some patients. If you don't treat somebody, You will find out whether they had melanoma or not. With time, it will grow and you'll find out. But if you treat them, you will never know what they had. And we have a paper that will come out within a few weeks. It's been accepted last week. It says that there is an element of overtreatment, about 30% in the US, because our methods are limited. We don't have good handle on it. It's just we need different ways. We have to move to different ways of figuring it out. Maybe biopsies, maybe the genetic mutations. I think that's the way it's going to be. But for now, whatever we are doing is not accurate.
That's fascinating for sure.
Yep.
And it sounds like, they're hard at work, researchers.
Yeah, people are trying. I mean, no
trying.
criticism of any kind, but there are inherent problems. You can only, get so much with so much.
Yeah, I hear you. So here's another question that we received. Is it too late to begin treatment with novel pharmaceuticals for radiation retinopathy 12 to 15 months after plaque radiation therapy?
So the question is all about prevention of radiation retinopathy. So 12 months went by, and I want to do something now. Well, you can, but there's nothing is proven yet. So it's like, I want to do something to prevent vision loss, but there's nothing proven with high level of evidence.
Right.
You can say, oh, there is this study and that study, and those are all studies, and we are aware of those studies, and they've been published, but they have a lot of limitations. We don't have very high level evidence. So if you want to have treatment and your doctor is willing to give it to you, you can have it. It may work great, and it may also not work, and you will never know that. But if it gives you some comfort, if somebody has one eye, somebody has some special situations, one can make those exceptions and take the benefit of doubt, let's say. But other than that, we don't routinely offer this because I think there may be, again, element of overdoing or overtreatment.
Mm-hmm.
So there's a burden of overtreatment. Let's not forget that. As much as we want treatments, there's also a burden of overtreatment.
And how that may affect someone's vision.
Yeah, and visits to the hospital and complications of the injections and the cost.
Of course, risks.
Yeah, all the different things. Yeah, it all adds up. It all adds up.
If loss of vision has already begun due to radiation, will these new treatments help stop further loss?
So that's the idea. So in the trial that we're talking about, AL trial, once the radiation retinopathy happens, then there is a way to treat it. And it's a prospective study. So that means it's all well controlled, everything is measured, everything is properly documented. So we can ascertain the effect of any treatment beyond doubt. The present studies are kind of going backwards because something was done, and then you go back and look at it, a lot of biases, etc. So yes, there is some, I would say, guarded improvements in certain cases, but some cases nothing can actually work. Nothing will work, I would say.
That actually fits well with the next question that we just received live, which is, what is the max time for RR to develop after initial treatment?
Well, we published a case of 42 years. Okay, 42 years. Okay, so radiation will damage the retinal cells, and in general, we say the median time is approximately 18 months, 24 months, some studies. So there is early presentation, and the general conventional wisdom is to say, if you didn't lose any vision in 5 years, then you will not. But it's very easy to predict this. It's not like a magic. You can look at the numbers as to how much was the dose to the optic disc and how much was the dose to the macula. And those numbers can give you a prediction very easily as to whether you will be at a risk of vision loss or not. But leave that aside. So as for the time frame, you say it's mostly in first 5 years. And there are outliers, of course, who can have damage after even 10 years and even longer, I said.
You mentioned the risk of metastases with small tumors and good genetic profile. What about large tumors with good genetic profiles? How long do the tumors usually take to grow? Hard question.
Yeah, it's a very question, a very good question, I have to say. So there are two things that are driving the risk of metastasis, at least two. There may be more, we don't know yet, but size for sure is one factor. And second is the genetics of the tumor. These are two. Genetics may be more significant than the size, but they interplay. They're not independent of each other. Smaller tumors have good genetics, bad tumors have bad genetics. Big tumors have bad genetics. Okay. And then when you adjust for size, there's some data to say that small tumors with bad genetics and small tumors with good genetics doesn't really matter. Small tumor is small and they'll do very well. And some large tumor with good genetics may actually behave just like small tumors. So size is an important factor. Genetics is also an important factor, but that has not been teased out very well as to the contribution of each. And there are new algorithms coming out, at least from the this Castle company. And I don't know whether they've adapted this in the new reporting system or not, but they do have a new study, COOG study, that has some new numbers that incorporate size also in the prediction and also brain status. So the way to think about all of it is to say that yes, we have ways to prognosticate melanoma, and very broadly we can say you're on the lower risk or high risk. And those numbers may not be accurate or maybe evolving. We say, oh, high risk, is it 50, is it 60, is it 33, is it 55? That number may change over time as more data comes and these things are defined. And the low risk is 5%, 4%, could be 3. So don't pay attention to the number necessarily, but just this broad category, I think, is a very valid categorization.
And what do you consider small and what do you consider big? Is that
Well, it's not my definitions. There are standard definitions that exist.
standards?
In the US, we follow COMS, Collaborative Ocular Melanoma Study Classification System, because that study was a first multi-center prospective study, had randomized components to it, and that gave a structure of size to the classification for tumors. So we use that in the US. In the European system, countries, people use mostly AJCC classification, which is American Joint Commission, but that's not so much used in America, but outside America, it's kind of strange. But in any case, so we refer when it says small melanoma, I'm referring to small melanoma of the Collaborative Ocular Melanoma Study, which is 5 to 16 millimeter in base, 1 to 2.5 millimeter in height. This tumor is a small tumor. So there's a definition, size definition of it.
Size definition and guidelines to help determine.
It's well published, well recognized, and well used. Everybody in this business knows about these boundaries.
How quickly must treatment start for RR, would you say?
For radiation retinopathy, it's also a slow process. It obviously starts the day you person gets radiation. So radiation retinopathy at the molecular level or the cellular level has started the day patient got radiation. And it's taken 18 months or 24 months to show up. And once the symptoms happen, there's no urgency to say, but it has to be done same day. But like anything else, if it's affecting somebody's vision and function, then you want to address it. I would say a week or 2 or 3 is reasonable. Waiting months and months is not good. So a few weeks up and down is fine. Months are usually not good.
Great, well, thank you. Those were all of the questions I received. So I wanted to just quickly talk about the upcoming Eyes on OM Ocular Melanoma Symposium that we are doing in partnership. We are very excited. Our Eyes on a Cure program. This will be happening, like I mentioned before, April 25th, 26th, and 27th in Cleveland. What can our patients, caregivers, and community look forward to?
Well, I can say they'll have 3 elements to a good retreat. It's a good city. Cleveland is a very beautiful place. Then you have a very generous host, which is Cleveland Clinic Cola Institute. And we're going to have a high level of education. We're going to talk about these trials, more details, more speakers, people expert in this business who are excited and committed to come up with new treatments. So I am certainly, after I told you before, after 30 years, these are the very exciting times in our business. And we'll also have a good party. That's included.
We will. Well, your enthusiasm and your energy, I can feel it through the screen, and we will definitely be able to feel it in person
I hope so.
in April. So very much looking forward to all of the sessions, all of the opportunities to connect with one another in community and come together to talk about OM and all the excitement there is with new discoveries. So with that, I'd like to thank you so much for speaking and for your for sharing with all of us your expertise, and for all of our listeners for joining us today for this Ask the Expert session. So thank you. We appreciate all that you do, Dr. Singh, for the melanoma community, and of course appreciate you taking the extra time this evening to be with us. This program will be available on YouTube, on our YouTube channel, in a few weeks. So look out for it there. And again, when you close your Zoom tonight, there will be a short evaluation. So please do fill that out. Again, please visit us at melanoma.org to learn more about upcoming events and webinars. And if you have any additional questions, you can reach out to me at cureom@melanoma.org. Thank you.
Thanks for having me. It's been a privilege. Thank you.
Thanks, everyone. Have a great evening.
Thank you.